Hello, my name is Bans Leshi. I'm an assistant professor in the Department of Anesthesiology at Vanderbilt Hospital. Today we'll go over ECGs or electrocardiograms and basic principles. Here is the learning objective for this module. We hope at the end of this module you'll learn that the electrocardiogram provides a graphic record of the electrical activity of the heart. And when we look at depolarization of the cardiac cells, it's important to know that it proceeds in an orderly fashion in a normal situation that starts at the sinus node and then spreads sequentially to the atrioventricular node and the ventricles. The sequential movement of the electrical current with each depolarization from the sinus node to the entire ventricle is what creates specific phases of the ECG, which we will go over. And then lastly, the electrical activity of the heart is captured by recording electrodes, or what we otherwise call leads, that are placed on both arms and legs, and as well as on the chest. Here is an outline of the talk. We're going to talk about the cardiac cell action potential, and then we'll go over ECG lead placement, and then touch on basic principles of ECG analysis. So we'll go ahead and start with cardiac cell action potential. So when we're thinking about ECG, the big thing I want you to have in your mind is it's about electricity and how we capture the electrical activity in the heart. So before we go through the specifics of what an ECG looks like and how we interpret it, I want us to think about how it's generated. Now, when we think about electrical activity in the heart, I like to think about two different conducting tissues. The one is what we call the electrical conducting system of the heart, and then the second is the rest of the heart muscles. Electricity goes through both the conducting systems and it goes through the heart muscles, and usually the conducting system facilitates spreading electricity in a timely and appropriate fashion to the rest of the heart muscles, so that the heart can contract in a coordinated fashion. So what constitutes the electrical conducting system? The electrical conducting system has the sinoatrial node, it has the intranodal pathways, and then it has the atrioventricular node, or the AV node, and then it has the bundle of His, then it continues to the right and left bundle branches, and then the Purkinje fibers, which spread throughout the left ventricle. So two types of tissues: the electrical conducting system, which really controls and expands the electricity in the heart to the rest of the heart muscles, and the second type of the tissues are the heart muscles itself, that are the atrium and the ventricle. So when we think about electricity in the heart, it is passed through what are called action potentials. So if you have muscle tissue, the way that it's able to contract is it receives electricity, and based on the electricity it received, certain channels are opened, and as those channels are opened, more electricity is passed, which allows for the muscle to contract. So now the way that action potential or the electricity is transmitted in the electrical conducting system is different from the ventricle action potential or the ventricular tissues. How are they different? The main big difference is that the electrical conducting system tissues have the ability to generate action potentials on their own without needing any stimulus from another cell. So here is what we call the nodal action potential, or the types of action potentials you would see in the electrical conducting system tissues, such as the SA node, the AV node, or the bundle of His. There are different phases, and each phase is not important for you to know. But if you think of time going in this direction and electrical activity going up in that direction, you see this phase 4, it's not, instead of being a horizontal line, it slowly increases up. And after it reaches a certain threshold in terms of millivolts, then more channels are open to where the charge in the cell is changed. And it's this surge that allows to pass the electricity from one cell to the adjacent or to the next cell. On the other hand, when you look at muscle tissue such as on the ventricle, if you look at their action potentials, their phase 4 is a horizontal line, as you can see right here. And in order for the action potential to be started, you have to have a stimulus. So a stimulus needs to come from an electrical conducting system tissue cell to allow the charge to be activated, so that once you reach a positive charge, the electricity is conducted to the muscle cell, which allows it to contract. So again, to re-emphasize this point, electrical conducting system tissues such as the SA node and the AV node have the ability to start electrical activity on their own and pass action potentials on their own without requiring a stimulus, whereas muscle tissues such as the ventricle require somebody giving them a stimulus of electricity for the action potential to be started. Okay, here I will show you what happens through one heartbeat and what happens to the electrical activity in the heart. So the electrical activity starts from the sinoatrial node, and up here you can see how that action potential goes in the SA node. The x-axis is time and the y-axis is voltage in millivolts. Then the SA node will send that signal to the internodal pathways, which will go to the atrioventricular node, which will subsequently pass the electricity to the bundle of His, and then that passes it to the right and left bundle branches, and then that passes the electricity to the Purkinje systems, and then that will disseminate through ventricular muscle. So as you can see, each electrical activity that is listed up here through time, based on when it is activated, the peak of the milliamps, the timing of the peak of the milliamps is different. And then if we add up all this electrical activity in one line, it will give us something that looks like this, which we refer to as our ECG tracing. So what's an ECG tracing? An ECG tracing is the collection of all the electrical activities in one, in a heartbeat, to where we track the electricity starting from the SA node going through all the electrical conduction system, as well as through the ventricular muscle. So we're going to go ahead and take a closer look at one cardiac cycle in terms of electrical activity in the heart, and we'll see that here as an ECG tracing. As we said earlier, the electrical activity starts from the SA node, passes through the nodal pathways, goes to the AV node, to the bundle of His, to the right and left bundle branches, and then to the Purkinje cells, and sends the electricity to the ventricular tissue. So when we add up all the electrical activity and try to look at it in one line, what it usually comes through, and if this represents time and up this way is a voltage in millimeters, the first summation that you would see is something called a P wave. And P wave corresponds to the electrical activity that's going in the atriums, and the atrium contracting, the electrical signal that's going through the atrium, and corresponds to atrial contraction shortly. And then we have something called a QRS. QRS is a summation of the electrical activity that's going on in the ventricle itself. And then lastly, we have something called T wave, which corresponds to repolarization in the ventricles, meaning the electrical signal going back to the baseline current. Okay, I hope by this point you kind of have an idea of what we mean by an ECG and what it corresponds to. So we're going to go into a little bit detail of how we place ECG leads in a human, and how that helps us look at the electrical activity in the heart from different directions. When we think about ECG lead placement, we like to divide it into three different categories. The first one is 3-lead EKG or ECG, depending on how you like to say it. The second one is augmented limb leads, or another way we refer to it is 5-lead ECG. And the third is what we call precordial leads. So I will go over each of these lead placements with you. So to do a 3-lead ECG, or another name for it is a limb lead system, you place 3 leads in the patient, one on the right hand, or you can place it on the right side of the shoulder. The second is in the left hand, or you can also place it in the left shoulder, and the third is on the left leg, or we typically put it in the patient's hip area. What this allows you is, and you can see the negative and the positive charge for each leads that we're going to see. So the first lead, or what's called as lead 1, would go from negative charge to positive charge from the right hand to the left hand. What we call lead 2 goes from the right hand to the left leg in this direction, from negative to positive charge. And then lead 3 would be from the left hand to the left leg, and the negative to positive would be in the direction that you see here. The second system is called augmented limb leads, or the 5-lead ECG. So in addition, this 5-lead ECG, what it allows you to do is, in addition to the 3 leads we saw earlier, which were lead 1, lead 2, and lead 3, by combining some of these leads, we're able to get additional information. For example, for lead AVR, you would look at a combination of the left hand and the left leads, as you can see here in the picture. That would be your starting negative charge, and then you would look at electrical signal going towards the right arm. So that would be called lead AVR. Another thing you can do is you can combine the right hand and the left lead together right here, and look at electrical signal from this point going in that direction towards the left hand, and that's called the AVL lead. Lastly, you can combine the right and the left hand together and use that as a negative and look towards the left leg electrical activity, and that will give you lead AVF. So this combination allows us to look at electrical activity in 3 more additional directions than we did earlier. The third ECG lead placement system is called the precordial leads. Because when we think about electrical activity in a patient, we really want to focus on the heart, we can add additional leads surrounding the heart that give us even more electrical activity information. So you can think of having the negative charge somewhere in the patient's back, and then you can put leads called V1 through V6 going around the heart, and I'll show you a picture in a little bit. And that will give you, electrical vectors going kind of all around the heart, and be able to look at the electrical voltage from different directions. Here is a picture of lead placements, precordial lead placements in a patient. As you can see, this would be V1, V2, V3, V4, V5, and V6. So all these are located around the heart, and they are able to give us electrical activity information from the heart from different angles. So when we put all those three different systems together, it gives us a total of 12 different angles and directions of looking at the electrical activity from the heart that we are able to do. So we have what we call the frontal plane leads. That includes lead 1, 2, 3, and AVR, AVL, and AVF, and then the transverse plane or the precordial leads that range from V1 to V6. And you can think of which direction is positive and which direction is negative, and I'll try to show you the importance of that. But the take-home message here is that all we're trying to do by adding all these different leads, by placing all these different leads in a patient, is to try and look at the electrical activity going through the heart, so we can get important information on which part of the heart is getting appropriate electrical conduction and which one is not. Okay, now that we've gone over what a cardiac cell action potential looks like and how we place ECG leads, I hope to go over some basic principles of ECG analysis with you. Okay, to quickly summarize what the leads we talked about so far look like. Again, lead 1 is from the right arm to the left arm, and it's negative to positive towards the right arm. Lead 2 would be from the right arm to the left leg, and you can see that the negative is on the right arm and positive is on the left leg. And then lead 3 would be from the left arm to the left leg, the negative being at the left arm and the positive being at the left leg. And then you can see where AVR, AVL, and AVF each direction going in positive towards the right arm, to the left arm, and to the left leg. So why am I emphasizing the negative and the positive signs of these leads? I'll try to show you here with an example. So let's say there are some cells and there's depolarization going in the horizontal direction, going from here to here. So cells are being depolarized and electrical signal is going from the left to the right in a horizontal direction. So if you have lead A that has its negative and its positive in this direction, then lead A is going to interpret this vector direction or this electrical activity, because it's in the same horizontal direction as lead A, is going to be read as a positive electrical signal from that lead. So when you look at the ECG, you will see a spike in that direction. But let's say you have lead B that is looking at that electrical signal, again horizontal and going in this direction, but lead B has negative here and positive there. Then on your ECG tracing, you're going to get a negative deflection on your paper, because the electrical activity is going opposite to where lead B has the negative and the positive signs. Okay, let's look at lead C. Now lead C, let's say, is perpendicular to where the electrical activity is going. Because it's perpendicular, then lead C is not going to pick up any electrical activity going in this direction, and on the ECG tracing you'll just have a horizontal line. So all these leads, what they do is they pick up electrical signal going in their direction, and based on whether it's the same direction or a positive direction, the deflection on the paper would be either positive or negative. So coming back to this figure and looking at the different leads we covered earlier, so if there is any electrical activity going in the patient, let's say in this direction, then you can see that lead 1 would read that as a positive inflection in the ECG tracing, whereas lead AVF would interpret that electrical activity as a straight line because it's perpendicular to the electrical activity. So I hope this helps you appreciate that we are able to look at electrical activity in the heart from different angles, and based on the positioning of our leads, we can pick up where there's a strong electrical activity going in one direction versus the other in the totality of the heart. So when we put it together, this is what a normal ECG would look like. A patient who has an ECG tracing from the 12 different leads that we mentioned earlier shows you 3 different beats represented here, 1, 2, 3, and depending on which lead you're looking at, the electrical activity appears in a different form. So we try to emphasize people to get used to or to learn what a normal ECG looks like, so that when there is change from the normal electrical activity, you'll be able to pick it up and be able to interpret abnormal findings in patients. Okay, so let's change our gears a little bit into some of the practical aspects of obtaining an ECG reading from a patient. So to be able to look at electrical activity in a patient, we normally print the ECG tracing once we place the leads on patients on a special paper. It's called ECG paper, and it has large and small boxes, and I'll show that to you on the next slide. But you can see here that if you obtain a 12-lead ECG on a person, you will have all 12 of the leads we mentioned earlier represented, starting from lead 1, lead 2, 3. You'll have the AVR, AVL, AVF, and you get these from the 5-lead ECG we mentioned. And then if you add the precordial leads, you'll get 12-lead ECG, which includes the V1, V2, V3, V4, V5, and V6. And usually they'll give you a long tracing of lead 2, so you can see what the heart electrical activity looks like in lead 2 in many beats. When you look at an ECG tracing, you'll see these little marks. So each little marks are the start of time, and the ECG is recorded in all the 12 leads starting at the same time, which is this click mark, and for a certain amount of number of seconds. And here you can see that we have been able to capture 3 beats, 1, 2, 3 in this block, and depending on how fast your patient's heart rate is, you might be able to capture 4 beats, or you might only be able to capture 2 beats, and we'll go over that a little bit later. But again, important things, you're seeing 12 leads here, and they happen at the same start time and finish time, and the start time is indicated with these small bars that I showed you earlier. And usually when they give you an ECG tracing, at the bottom they will show you a very long run of lead 2 by itself, so that you can monitor the electrical activity in prolonged time. This is a magnification of what the ECG paper looks like. You can see it has large boxes, and then in each large box you have 5 small boxes. And in terms of speed or time, from one large box to another box it's 0.2 seconds, and the time from one small box to another small box is 0.04 seconds, and that is what is represented in the x-axis. On the y-axis we have voltage, and 10 millimeters or 10 small boxes is equivalent to 1 millivolt. So this is what a typical recording from one of the leads would look like, for example lead 2. And let's look at the different components of the electrical signal we see and what that corresponds to the cardiac cycle. So the P wave corresponds to atrial polarization. The QRS corresponds to ventricular polarization, and T wave corresponds to ventricular repolarization. And there are certain intervals that we look at. We look at from the time the P starts until the QRS starts. We call that the PR interval. And then the time of the QRS itself is called QRS interval. And then another important thing that we look at is something called the QT interval, which is from the start of Q until the end of the T. So in typical patients, there are expected times for these different intervals. For example, a P wave usually should last less than 0.12 seconds, or which would be equivalent of 3 small boxes. On the other hand, a PR interval should be between 0.12 to 0.2 seconds, so anywhere from 3 to 5 small boxes. And then a QRS shouldn't be more than 0.12 second, which is equivalent to anywhere from 1.5 to 2.5 small boxes. And then lastly, a QT interval should not be more than 0.44 seconds. And here we're talking about what we should expect to find in normal patients. So even by just looking at these time intervals, you're able to start to appreciate if someone has normal conduction or abnormal conduction system. So you can look at somebody's ECG tracing and be able to determine their heart rate. Two shortcuts we use are 300 divided by number of large boxes between two QRS complexes, or you can do 60 divided by time between QRS complexes. And I'll show you a couple of examples. So if we look at the top tracing, from one QRS to another QRS, we have 1, 2, 3, 4, 5, 6, almost 6.5 large boxes. So if I do 300 divided by 6.5, that gives me a heart rate of 46. Alright, the other way we said we can calculate this is 60 divided by the time between the two QRS. As we said earlier, each large box corresponds to 0.2 seconds. So we have 0.2, 0.4, 0.6, 0.8, 1, 1.2, and let's say 1.25 seconds. So if I do 60 divided by 1.25 seconds, that would give me a heart rate of 48. So you can see how I'm able to calculate the heart rate based on just looking at the ECG tracing. So let's look at the second tracing. The second tracing, it looks like between two QRSs I have 1, 2, so maybe 2.5 large boxes. So 300 divided by 2.5, that gives me a heart rate of 120. Or another way to do it is each small box is 0.2, 0.4, so 0.5. So if I do 60 divided by 0.5, gives me 120. One last example. So between these two QRSs, I have 1, 2, 3, almost 4 large boxes. So 300 divided by 4 would give me 75. If I wanted to do it the other way, it would be 0.2, 0.4, 0.6, 0.8, then it would be 60 divided by 0.8, which gives me 75. So you'll be able to determine patient's heart rate by just doing this calculation. So to summarize what we've covered in the basic principles of ECG analysis section, remember we have 12 different leads or vectors that we place on the heart to be able to pick up electrical activity from the heart from different angles to help us with representation. When we print an ECG signal, we print it on a specialty paper that has large and small boxes, square boxes in it, that helps us determine how long the heart rate is, and it also tell us how large the voltage is by looking at the x-axis. So the more you familiarize yourself with what a normal ECG looks like, what a normal ECG pattern is supposed to look like, then you will have the ability to identify when someone has abnormal electrical activity from their heart based on the change from what normal looks like. So to re-emphasize the learning objectives of this lecture, I hope you have recognized that the ECG provides a graphic record of the electrical activity of the heart, and depolarization of the cardiac cell proceeds in an orderly fashion in a normal situation that begins from the SA node and then spreading sequentially through the atria to the AV node and to the ventricles, and that the sequential movement of electrical current with each depolarization from the sinus node to the entire ventricular myocardium creates specific phases of the ECG. And that lastly, the electrical activity of the heart is captured by recording electrodes or leads that are placed on both the arms and the legs, which we call the limb leads, and 6 on the chest that we call the precordial leads. Thank you for your attention.